Все. Good afternoon, dear students. Our topic, arterial hypertension. What does it mean, arterial hypertension? Arterial hypertension is a pathological condition which characterized by constantly increased systolic, more than 140 or same millimeter mercury, and or diastolic blood pressure, more than 90 or same millimeter mercury, which we can reveal not less than 3 times during 4 weeks. And arterial hypertension divided on primary and secondary hypertension. Secondary or symptomatic arterial hypertension is an hypertension, the cause of which can be revealed. Therefore, this is a syndrome of the underlying primary disease. And primary hypertension, pathological condition in which unknown, cause of which cannot be revealed, and unknown etiology. And hypertension is defined as values more than 140 systolic millimeter mercury and or more than 90 or same millimeter mercury diastolic blood pressure based on the evidence from randomized controlled trials that in patients with these blood pressure values treatment-induced blood pressure reductions are beneficial. And arterial hypertension can cause injury of target organ affection. And arterial hypertension is a silent killer of 21st century. It's a major cardiovascular risk factor that directly contributes to myocardial infarction, chronic heart failure, cerebrovascular accidents, peripheral arterial insufficiency, and premature mortality. Silent killer because in initial stages of development, disease not associated with complaints of patients. And arterial hypertension can lead to target organ affection. What does it mean, target organs? CNS and in arterial hypertension, strokes develops from 7 to 10 times more frequent. Second target organs, heart, and in arterial hypertension, myocardial infarction, 4 to 5 times more frequent. Third target organ, eyes, exudates associated with retina, ischemia or infarction, papillary edema. Kidneys are affection associated with proteinuria and progressive renal failure. Peripheral arteries associated with affection of peripheral arteries associated with development of atherosclerosis, aortosclerosis, formation of chronic aneurysm. And actuality of our topic associated with prevalence of arterial hypertension in cardiovascular diseases, and arterial hypertension consists of 33% of the population in United States of America and more than 40% in Russia. Overall, the prevalence of hypertension appears to be around 30 to 45% of general population, with a steep increase with aging. And more than 65 years suffered from 60 to 70% of all population. A close relationship between prevalence of hypertension and mortality for stroke has been reported. The incidence and trends of stroke mortality in Europe have been analyzed by use of World Health Organization statistics. And in 2020 years, 2.6 million Indians are predicted to die due to coronary heart disease, which constitutes 54.1% of all cardiovascular death. The Sentinel surveillance project documented 28% overall prevalence of hypertension from 10 regions of India in the age group 20 to 69. In Nigeria, prevalence of hypertension consists of 28.7%. Hypertension prevalence was comparable in men and women, and hypertension was more prevalent in semi-urban than rural villages. Predisposing factors of arterial hypertension. Risk factors. At first, age, more than 60 years. Sex, genetic, and men and postmenopausal women. Family history of cardiovascular disease, genetic predisposition. Smoking. High cholesterol diet. Coexisting disorders such as diabetes mellitus, obesity, hyperlipidemia, high intake of alcohol, sedentary lifestyle. Structure of diagnosis of arterial hypertension consists of 4 parts. In first place, primary or secondary arterial hypertension. If primary, essential hypertension, or secondary, if secondary arterial hypertension occur. And in first place must be underlying disease. For example, chronic kidney disease, chronic glomerulonephritis, and then secondary arterial hypertension. Second part of diagnosis, degree of arterial hypertension. Degree according to blood pressure level. In third place, stage of arterial hypertension. Stage depends on impairment of target organs effect, target organs. And in fourth place, stratification of risk for individual. "94 to 95% of all cases constitute primary arterial hypertension or essential hypertension. Only 5 to 6% consist of secondary arterial hypertension. In structure of secondary arterial hypertension, 4 to 5% consist of renal parenchymal diseases, and only 1 to 2% other reasons. Classification of arterial hypertension according to blood pressure level. And before discussion of arterial hypertension, we must remember about normal blood pressure and three main categories of normal blood pressure. Optimal blood pressure, in case when systolic blood pressure consists of less than 120 mm mercury and or diastolic less than 80 mm mercury. Normal blood pressure less than 130 mm mercury systolic blood pressure and less than 85 mm mercury diastolic blood pressure. And high normal arterial pressure consists of 130 to 139 mm mercury systolic blood pressure and 85 to 89 mm mercury diastolic blood pressure. Arterial hypertension consists of three grades or 3 degrees. First grade or first degree we are established when systolic blood pressure consists of 140 to 159 mm mercury and or diastolic blood pressure consists of 90 to 99 mm mercury. Second grade or second degree we are established when systolic blood pressure consists of 160 to 179 mm mercury and or diastolic blood pressure consists of 100 to 109 mm mercury. And severe arterial hypertension, third grade or third degree of arterial hypertension, we are established when systolic blood pressure consists of 180 and more millimeter mercury and or diastolic blood pressure consists of 110 and more millimeter mercury. Classification of arterial hypertension according stages. Arterial hypertension divided on three stages. Stage 1 characterized by no objective signs of target organ affection. Uncomplicated stage. Stage 2 objective signs of target organ affection present but without its dysfunction. In our practice, stage 2 characterized by appearance of left ventricle hypertrophy, which we can reveal on percussion, on objective investigation, or in instrumental methods, more correctly by ECG, by echocardiography, or by X-ray. Second criteria of second stage, generalized narrowing of arteries of retina. And or third criteria of stage 2, microalbuminuria or proteinuria or increased creatinine in plasma, but less than 177 micromole per liter. Stage 3 characterized arterial hypertension, characterized by objective signs of target organ affection with its dysfunction. Complicated stage. Second stage, asymptomatic stage, and third stage, complicated stage. And in third stage, we can reveal stroke, hypertensive encephalopathy, maybe transient ischemic attack, hemorrhage in retina, acute coronary syndrome, chronic heart failure, life-threatening arrhythmias, renal failure, aortic dissection. Stage 1, uncomplicated stage. Stage 2, asymptomatic stage. Stage 3, complicated stage, associated with cardiovascular disorders and associated with complications. Next component of diagnosis, cardiovascular risk. Assessment of total cardiovascular risk concept is based on the fact that only a small fraction of the hypertensive population has an elevation of blood pressure alone, with the majority as exhibiting additional cardiovascular risk factors. Estimation of total cardiovascular risk is easy in particular subgroups of patients, such as those with antecedents of established cardiovascular disease, diabetes, coronary heart disease, or with severely elevated single risk factors. In all of these conditions, the total cardiovascular risk is high or very high, calling for intensive cardiovascular risk reducing measures. However, a large number of patients with hypertension do not belong to any of the above categories, and the identification of those at low, moderate, high, or very high risk requires the use of models to estimate total cardiovascular risk so as to be able to adjust the therapeutic approach accordingly. Assessment of total cardiovascular risk. Classification in low, moderate, high, and very high risk is retained in the current guidelines and refers to the 10-year risk of cardiovascular mortality as defined by the 2012 European Society Cardiologist Prevention Guidelines. The factors on which the stratification is based are summarized in next page. Factors other than office blood pressure influencing prognosis used for stratification of total cardiovascular risk. At first, male sex, age, man more than 55 years or same, woman more than 65 years or same. Smoking, dyslipidemia, total cholesterol more than 4.9 millimole per liter, and or low density lipoprotein cholesterol more than 3 millimole per liter, and or high density lipoprotein cholesterol, men less than 1 millimole per liter, women less than 1.2 millimole per liter, and or triglycerides more than 1.7 millimole per liter. Next risk factor, fasting plasma glucose, consists of 5.6 to 6.9 millimole per liter. Abnormal glucose tolerance test, obesity, body mass index more than 30 kilogram per meter square or same. Abnormal obesity waist circumference in men more than 102 centimeter or same. On women, in women more than 88 centimeter or same. Family history of premature cardiovascular disease. Men age less than 55 years, women age less than 65 years. Asymptomatic organ damage, such as pulse pressure, more than 60 millimeter mercury, or say difference between systolic and diastolic pressure, systolic minus diastolic pulse pressure. ECG criteria of left ventricle hypertrophy, such as Sokolov-Lyon index more than 35 millimeters, voltage of R wave more than 11 millimeters, corneal voltage duration product more than 244 millivolt, or as echocardiographic criteria of left ventricle hypertrophy. Left ventricle mass index in men more than 115 gram per meter square, in women more than 95 gram per meter square. Carotid wall thickening, intima media thickness more than 0.9 millimeter, or atherosclerotic plaque, carotid femoral wave more than 10 meter per second, ankle brachial index less than 0.9, chronic kidney disease with glomerular filtration rate consists of 30 to 60 milliliters per minute, microalbuminuria from 30 to 300 milligrams per 24 hours, or albumin creatinine ratio. Preferentially on morning spot urine. Diabetes mellitus risk factor, or fasting plasma glucose, in which fasting plasma glucose more than 7 millimole per liter was same on 2 repeated measurements. And or hemoglobin more than 7, post-load plasma glucose more than 11 millimole per liter, established cardiovascular or renal diseases, cerebrovascular disease such as ischemic stroke, cerebral hemorrhage, transient ischemic attack, coronary heart disease, which include myocardial infarction, angina pectoris, myocardial revascularization with percutaneous coronary intervention, PCI, or CABG, coronary artery bypass graft. Heart failure, including heart failure with preserved ejection fraction. Symptomatic lower extremities peripheral artery disease. Chronic kidney disease with glomerular filtration rate less than 30 milliliter per minute, or proteinuria more than 300 milligram per 24 hours. Advanced retinopathy, hemorrhages or exudates, papillary edema. Risk factors which were used for stratification of total cardiovascular risk. Classification of hypertension stages according to blood pressure level, presence of cardiovascular risk, hypertension-mediated organ damage, or comorbidities. Cardiovascular risk is illustrated for mid-aged male. The cardiovascular risk does not necessarily correspond to the actual risk at different ages. The use of the SCORE scale is recommended for formal estimation of cardiovascular risk for treatment decisions. In stage 2, uncomplicated stage, occur low, moderate, or high risk. In high normal blood pressure, if no other risk factors, occur low risk. If high normal blood pressure and one or two risk factors present, the same, occur low risk. But if we reveal in high normal blood pressure more than 3 risk factors, in this case we are established moderate risk. In grade 1 arterial hypertension, low risk occur if no risk factors. Moderate risk if 1 or 2 risk factors. And moderate or high risk occur if we reveal more than 3 risk factors. In grade 2 of arterial hypertension, if no risk factors, moderate risk. If 1 or 2 risk factors, moderate or high risk, occur. And in grade 2 of arterial hypertension, if we reveal more than 3 risk factors, occur high risk. And grade 3, no depends of risk factors, only blood pressure risk, high blood pressure risk, severe blood pressure, severe hypertension, characterized by high risk of complications, high risk of cardiovascular events. In stage 2, asymptomatic disease. In high normal arterial pressure, we are established moderate or high risk because chronic kidney disease, grade 3, or diabetes mellitus present without organ damage. Or hypertension-mediated organ damage. In grade 1, in stage 2 occur high risk. In grade 2, the same, high risk. And in grade 3, in stage 2, high or very high risk. And in stage 3, complicated stage, established disease, cardiovascular disease. Occur a very high risk in all grades and in high normal arterial pressure. How we measure arterial pressure, blood pressure? The main principles. Use a machine that has been validated, well maintained, and properly calibrated. Measure sitting BP routinely with additional standing BP in elderly and diabetics. Remove tight clothing from the arm. Support arm at the level of the heart. Lower mercury slowly, 2 mm per second. Read BP to the nearest 2 mm mercury. Use phase 5, disappearance of sounds, to measure diastolic blood pressure. Take 2 measurements at each visit. Types of measurement: office BP, home BP, and daily monitoring of BP. Up to 13 to 15% of apparent hypertension in the clinic may normal blood pressure when it is recorded by automated use in their own home. Office BP, sometimes associated office arterial hypertension, sometimes associated with white coat. Primary hypertension, arterial hypertension, unknown etiology, and the secondary hypertension associated with underlying primary disease. And the classification of secondary arterial hypertension consists of some parts. In first place, renal arterial hypertension, renal parenchymal, renovascular, or anephric. Second group of reasons of secondary arterial hypertension, endocrinological diseases, such as Cushing syndrome and Cushing disease, primary hyperaldosteronism, pheochromocytoma, primary hyperthyroidism, hyperthyroidism, hypothyroidism, acromegaly, hyperparathyroidism. Third group of diseases which can cause secondary arterial hypertension, neurogenic diseases, increased intracranial pressure, in tumors, inflammatory diseases, meningitis, arachnoiditis, encephalitis, severe trauma can cause arterial hypertension. Hypothalamic syndrome, the same, can cause arterial hypertension. Cardiovascular diseases, the same, can cause secondary arterial hypertension, such as coarctation of aorta, patent ductus arteriosus in younger patients, congenital diseases, atherosclerosis of aorta in elderly, if we reveal arterial hypertension in patients more than 65 years, usually it's situation associated with atherosclerosis of aorta. Insufficiency of aortic valve, aortic regurgitation, one of the diagnostic criteria of aortic regurgitation, high pulse pressure, high systolic and low diastolic pressure. Complete AV block associated with can cause arterial hypertension. Congestive chronic heart failure due to increased circulatory volume can cause arterial hypertension. And polycythemia. Arterial hypertension depends on stroke volume and circulatory volume. And peripheral resistance of arteries. Iatrogenic, pharmacological. Iatrogenic reasons of secondary arterial hypertension associated with usage of medicines. And some drugs, such as corticosteroids, non-steroid anti-inflammatory drugs, can cause arterial hypertension. Excessive thyroxine, oral contraceptives containing estrogens, sympathomimetics, which we are using chronic obstructive pulmonary disease or in bronchial asthma. Anabolic steroids, the same, can cause secondary arterial hypertension. In arterial hypertension, investigation of arterial hypertension include except physical examination, laboratory and instrumental methods. Hemoglobin and or hematocrit. Routine tests consist of definition of CBC, fasting plasma glucose, serum total cholesterol, low density lipoprotein cholesterol, high density lipoprotein cholesterol, fasting serum triglycerides, serum potassium and sodium, serum uric acid, serum creatinine with estimation of glomerular filtration rate, urine analysis with investigation with microscopic examination, urinary protein by dipstick test, test for microalbuminuria, and routine instrumental test, ECG. And obligatory investigation to detect the secondary hypertension. Chest X-ray to detect cardiomegaly, heart failure, coarctation of aorta. Ambulatory blood pressure recording to assess borderline or white coat hypertension. Echocardiography to detect or quantify left ventricular hypertrophy. Renal ultrasound to detect possible renal disease. Renal angiography to detect or confirm presence of renal artery stenosis. Urinary catecholamines to detect possible pheochromocytoma. Urinary cortisol and dexamethasone suppression test to detect possible Cushing syndrome. Plasma renin activity and aldosterone to detect possible primary aldosteronism. For treatment, management of arterial hypertension consists of non-pharmacological and pharmacological methods. Non-pharmacological methods include lifestyle modification, decrease or exclude risk factors, loss of weight or if overweight or obesity, limit alcohol intake, increase physical activity, reduce salt intake, stop smoking, limit intake of foods rich in fats and cholesterol. And if occur secondary arterial hypertension, in first place, etiological management, elimination of causes, treatment of underlying primary disease, and non-pharmacological management, which reduce risk factors and elimination of risk and exclude risk factors. And principles of pharmacological treatment of arterial hypertension: long-term, lifelong administration of antihypertensive drugs, long-acting drugs 1 to 2 times per day, combined prescription of 2 to 3 or more medicines. According to guidelines, 5 groups of medicines, of drugs, we are used for management of arterial hypertension. In the first place, AC inhibitors or angiotensin II receptor blockers, if intolerance to AC inhibitors occur. Beta blockers, calcium channel blockers, and diuretics. We are used for management of arterial hypertension. AC inhibitors include enalapril, lisinopril, perindopril, ramipril. Angiotensin II receptor blockers include losartan, valsartan, telmisartan, azilsartan, etc. Beta blockers include usage of bisoprolol, metoprolol, nebivolol, carvedilol. Diuretics includes hydrochlorothiazide, like thiazide-like diuretics such as indapamide, chlorthalidone, calcium channel blockers include dihydropyridine origin calcium blockers such as amlodipine, felodipine, lercanidipine, and strategies of treatment. Treatment is permanent and continuous. Begin treatment with a minimal dose and gradually increase to reduce blood pressure. Gradually decrease of blood pressure. The choice of drug taken accordingly hemodynamics, coronary insufficiency, arrhythmias, cardiovascular disease risk factors, target organs damage, concomitant diseases. Treatment step by step, stepwise therapy. Monotherapy, combination of 2 drugs, combination of 3 drugs, and combination of 4 drugs and more. And rational combinations. of uh, drugs. Prolonged drugs use. Usually we use combination of ACE inhibitors with calcium channel blockers or diuretics, and or angiotensin II receptor blockers with calcium channel blockers or diuretics. Combination of ACE inhibitors with angiotensin II receptor blockers contraindicated. In the first place of secondary arterial hypertension occur renal parenchymal diseases such as chronic glomerulonephritis, pyelonephritis, polycystic renal disease, diabetes mellitus, which can cause diabetic nephropathy, congenital diseases of kidneys, vasculitis and systemic connective tissue diseases, amyloidosis of kidneys, and renal tumors. Usually clinical manifestation associated with uh, uh, pain in the back, maybe pain in the loin, fever, signs of intoxication, weakness, fatigue, dysuria, frequent weak urination, nocturia, okay. Renal edema, nephrotic syndrome, symptoms of chronic renal failure. Diagnostics of renal parenchymal diseases associated with laboratory and instrumental methods of investigation, except clinical manifestations. And the urinary syndrome um, uh, characterized by proteinuria, leukocyturia, hematuria, cylindruria, bacteriuria, in chronic glomerulonephritis, hematuria and proteinuria, in chronic pyelonephritis, leukocyturia and bacteriuria occur. And for estimation of renal function, we use GFR, glomerular filtration rate, and isotopic renography. Calculation of GFR is the main method of estimation of chronic kidney disease, stages of chronic kidney disease. And instrumental diagnostics, excretory urography, ultrasound investigation of kidneys, radionuclide, renal scintigraphy, and rare biopsy. And mechanism of development of arterial hypertension in renal-parenchymal diseases associated with renin-angiotensin-aldosterone system. Activation of renin-angiotensin-aldosterone system can cause arterial hypertension. And the main vasoconstrictor, angiotensin II, which can cause arterial smooth muscle which can lead to arterial smooth muscle and activation and vasoconstriction. And systemic arterial pressure depends on two main factors: stroke volume and cardiac output, and vascular resistance. Renovascular arterial hypertension uh, appears in atherosclerosis in old men with widespread atherosclerosis. In younger patients, fibromuscular hyperplasia, and in younger patients maybe systemic vasculitis, arteriitis, Takayasu disease, and tumor can cause compression of renal artery, and the same uh, can cause stable and high blood pressure level and arterial hypertension resistant to antihypertensive management, antihypertensive treatment. Renovascular disease associated with appearance of murmurs in the paraumbilical region during auscultation. And instrumental methods such as renal arteriogram and Doppler echocardiography of renal vessels help us for establish diagnosis of vascular reason of arterial hypertension. Treatment of renovascular disease is only surgical. Surgical revascularization, renal percutaneous transluminal angioplasty, and pharmacological methods usually no help. Pheochromocytoma. In 1% of all cases occur in secondary arterial hypertension. Rare tumor of chromophene cells, adrenal medulla of kidneys, or symptomatic ganglia in the abdomen or the chest can lead to hypersecretion of norepinephrine and epinephrine and development of arterial hypertension. Arterial hypertension with crisis. Clinical features in pheochromocytoma are paroxysmal sweating, flushing, palpitation, increased blood pressure in supine position and decreased blood pressure when standing up, loss of weight, activation of sympathadrenal system can cause arterial hypertension. Diagnosis based on elevated urinary excretion of vanillyl mandelic acid and metanephrine, hyperglycemia and glucosuria, angiochromocytoma, ultrasound investigation of kidneys can reveal tumor of the medulla. CT, MRI help us for establish diagnosis. And main method of treatment, surgical removal of the tumor. And before surgical method, can use phentolamine and beta blockers. Primary hyperaldosteronism, Cone syndrome, characterized by development of adenoma of the adrenal or adrenal hyperplasia. This situation leads to oversecretion of aldosterone and increased excretion of potassium and sodium retention, water retention, and increased circulatory volume and stroke volume, which can cause increased blood pressure. In primary hyperaldosteronism, due to increased excretion of potassium, occur hypokalemia. Usually, primary hyperaldosteronism suffered women below age 40 years, sometimes non-specific, mild or moderate arterial hypertension. Symptoms related to potassium depletion, nocturia, polyuria, thirst, muscular fatigue and paresthesias, arrhythmias on auscultation and on ECG can reveal. Diagnosis of Cone syndrome or primary hyperaldosteronism based on a hypokalemia less than 3.5 millimole per liter, increased sodium in serum, decreased renin, and increased aldosterone in plasma. During instrumental method help us for identification of a tumor. We used ultrasound investigation, CT, treatment of hyperplasia, antihypertensive drugs, including spironolactone, and treatment of adenoma, surgical strategy, resection of adrenal tumor. Cushing disease or Cushing syndrome. Cushing disease is a primary tumor of anterior pituitary gland, can lead to bilateral adrenal hyperplasia and oversecretion of cortisol, hypercortisolism, can lead to retention of sodium and water, increased aldosterone production, and increased circulatory volume. Circulatory volume causes arterial hypertension. Increased circulatory volume causes arterial hypertension. All reasons of hypercortisolism without proved pituitary tumor are called Cushing syndrome. The main clinical manifestation of Cushing disease and Cushing syndrome: moon phase, central obesity, vascular weakness, purple stria, acne, hirsutism, osteoporosis, alopecia, steroid diabetes, and all signs and symptoms associated with mild or moderate arterial hypertension. Moon-like face and purple stria you can see on these pictures. Diagnostics and treatment of Cushing syndrome or disease. Diagnostics based on increased ACTH and cortisol level in the blood, and instrumental methods, visualization of the tumor, X-ray tomography, we use X-ray tomography, CT of the pituitary and adrenal glands. And laboratory investigation include appearance of hyperglycemia and glucosuria. Treatment: micro-resection of the tumor, chemotherapy, pathological of thyroid gland, pathology of thyroid gland. At first, hyperthyroidism, grave disease, and TSH receptor antibodies can lead to stimulation of thyroid gland and can lead to influence of T3 and T4 on metabolism and increase stroke volume and increase systolic blood pressure. And clinical manifestation associated with central nervous system disorders, nervosis, irritability, and cardiovascular signs and symptoms such as palpitation, heart pain, piercing pain, and maybe generally sweating, weight loss, fatigue, weakness, and eyes symptoms, clinical findings. We review exophthalmos, diffuse enlargement of the thyroid gland, tachycardia on auscultation, sometimes appears atrial fibrillation, disturbances of rhythm, hand tremor, and eyes signs and symptoms, Grefé, Kocher, Stellwerk symptoms. Diagnosis based on appearance of revealing of increased TSH, increased T3, increased T4, thyroxine in the blood, increased uptake of iod-131 by the thyroid gland, ultrasound investigation, and radionuclide scanning. In treatment, we use anti-thyroid drugs, radioiodide treatment, subtotal thyroidectomy, and symptomatic beta blockers for decrease heart rate. Acromegaly, pituitary adenoma, can cause arterial hypertension. Hypersecretion of growth hormone lead to sodium retention and water retention, increase circulatory volume, and arterial hypertension. Usually, acromegaly suffered 40 to 50-year-old man with general coarsening of features. The nose and ears are enlarged. The prominently jaw, the large zygomatic arches, supraorbital ridges, skin folds are exaggerated. A harsh voice, plus maybe diabetes mellitus, a nodal or diffuse goiter. On X-ray, we can reveal hyperostosis, in blood high level of growth hormone, and surgical treatment, adenoidectomy. Cardiovascular diseases can lead to arterial hypertension. In elderly, atherosclerosis of aorta, increased rigidity of aorta lead to increased systolic arterial pressure, and maybe high pulse pressure, blood pressure consists of, for example, 180 over 80 millimeter mercury diastolic. And during auscultation over aorta can reveal systolic murmur, harsh hoarse systolic murmur in the second intercostal space to the right and over Botkin point. And can reveal signs of general atherosclerosis, peripheral atherosclerosis. Aortic insufficiency, aortic regurgitation, due to rheumatic fever, due to infective endocarditis, due to syphilis. And in aortic regurgitation, main clinical signs and symptoms associated with ischemia of brain and ischemia of the heart, and maybe dizziness, syncope, disturbances of consciousness, and maybe heart pain like angina pectoris. In this case, occur high systolic and low diastolic pressure. During auscultation, we revealed diastolic murmur over the second intercostal space on the right, over aorta, and diastolic murmur may be over Botkin point. Verification of diagnosis. For verification of diagnosis, we use echocardiography and Doppler echocardiography. Coarctation of aorta, congenital defect associated with hyperemia of the face and neck, hypertrophy of the upper part of the trunk, and atrophy of legs. Increase blood pressure on arms and decrease blood pressure on legs. And normal blood pressure in lower extremities higher than upper extremities on 20 to 30 millimeter mercury. In coarctation of aorta, opposite. For verification of diagnosis, we use echocardiography and Doppler narrowing, and can reveal narrowing of aorta. Complete AV block, atrioventricular block, the same can cause arterial hypertension due to increased stroke volume, and bradycardia can lead to ischemia of brain and Margani-Adams-Stokes syndrome attacks, disturbances of syncope and disturbances of consciousness. And on ECG, we reveal bradycardia and AV dissociation. AV dissociation. Polycythemia, the same, one of the reasons of cardiovascular disease, which can polycythemia can cause arterial hypertension. Neurogenic arterial hypertension associated with traumas, meningitis, encephalitis, arachnoiditis, cerebral atherosclerosis, tumor of the brain. And the clinical signs and manifestation characterized by severe headache, dizziness, epilepsy attacks, signs of organic injuries of CNS and mental disorders. Ophthalmoscopy helps us for verification of diagnosis. And instrumental methods such as X-ray, CT, electroencephalography, MRA. And thank you for attention. I wish you success.